Sheikh, Prof. Dr. Osama Mansour, Dr. Islam Dusuqi. Dear our attendees, welcome to in one of our SGH webinar. Today our webinar will be in endovascular therapy in acute ischemic stroke. Allow me to introduce our moderator today. He is the neurology specialist in SGH Medina, our famous Dr. Muhammad Fuad. Please, Dr. Muhammad.
Thank you so much, Mr. Ala, for that kind presentation. And shall I welcome our eminent speaker, Professor Dr. Basim Sheikh, Professor Dr. Osama Mansour, and Professor Dr. Islam Dusuqi. Today we have a very important webinar about endovascular therapy in the acute ischemic stroke, standard and non-standard indication. As we know all, that stroke is the second leading cause of death, and the most important factor in stroke is time factor. In the last decades, great achievements and developments in the field of stroke treatment in order to limit disability and provide accurate treatment at the exact time with best outcome and performance. Despite thrombolytic therapy being the first line of treatment of acute ischemic stroke, but a lot of inclusion-exclusion criteria which limit its use, and also the time needed for treatment with thrombolytic therapy. And mechanical thrombectomy solve for us many problems like large vessel occlusion, and the time window for it is greater than thrombolytic therapy. That's the importance of our today webinar. And I shall start with Professor Dr. Basim Sheikh, Professor of Neurosurgery at Tiba University, and also Professor of Skull-Base Surgery and Interventional Neurology. We will start with him, but first I'd like to alert our audience that you can hit the question answer icon, and we will answer all questions at the end of the presentations of all our speakers. Now I shall start with Professor Dr. Basim Sheikh. The mic is yours now, you can start.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. I would like to thank the organizing committee, Dr. Muhammad, Al-Ustaz Ala, for this kind invitation and participation in this important event to share with you our experience and tips and tricks about the management in the acute ischemic stroke, mainly the mechanical thrombectomy. So if I can share my ايش الاخبار يا استاذ علاء؟ is it clear with you؟ واضح عندك
very nice. You can start دكتور ما شاء الله.
طيب
Thank you.
أنا ببدأ هنا. طيب تمام. So is it you see
very nice.
Yeah, you see, if we entered into any of the emergency room in any of the institutions like yours, you will be faced with a patient who is screaming, holding his chest and dying from chest pain, and he is diagnosed as acute MI, for which he is rushed immediately to the angio suite, or a child with a seizure where all the medical staff are rounding him and trying to stop the seizure, or somebody who is just crying for the sake of his mother or some milk. But unfortunately, the whole staff is just ignoring somebody who is calm, quiet, maybe sleepy, not speaking, and he is thrown in the corner of the emergency room. And this is the topic of our tonight talk. Now, imagine that in a nation, in a given nation, the acute ischemic stroke outnumber the whole other neurovascular pathology, and this give you idea about the importance of the management of acute ischemic stroke. World Health Organization have announced that every 2 seconds, a victim is announced to have a stroke or acute ischemic stroke. Out of these, every 6 seconds, a victim is announced as dead. Now, this will give you the magnitude of the problem in a given society. And Saudi Arabia is not immune for that, because we have multiple studies in different regions of Saudi Arabia, and this is showing a range of about 60 cases per 100,000 population. But keep in mind that we are a growing population. So each year, the number of cases is increasing. This is, on one hand, reason because of the increase in the population of Saudi Arabia, and on the other hand, because of the increase in the age also of the society. So we are expecting to have an 18,000 case per year, which is not a small number. Now, coming to the management itself, it has been since the 1990s, many trials that have tried to implement the management during the acute stage of the stroke, but none of them attained very good results to be established. Now, in my opinion, it's only until the 2015 where 5 randomized clinical trials, and they simultaneously showed a very clear benefit of mechanical thrombectomy in the management of acute ischemic stroke. Not only that, but they started with the first 6 hours, but then studies have went on to establish also the benefit of having the mechanical thrombectomy even within 24 hours with special selection criteria. So this have pushed also the limit for the benefit of the patient having this attack. Now, the procedure had developed a lot since the start of the 90s. And we will go through some of these tips and tricks that we will share with you from our experience. The access is known to everybody that we always have the femoral arterial access for the diagnostic and interventional and neurosurgical or neuro intervention procedure, including the management of the acute ischemic cases. But it has been shown that the radial approach has a very good application in these cases, and we have adopted the cardiology move toward the radial first access, and in our experience in Saudi German Hospital Al Medina region, we adopted also the radial first access, and because of the reasons that we will see in a minute. Now, to start with, it has been only adopted for diagnostic, and then we implemented the procedure for diagnostic as well as the therapeutic, including the acute ischemic stroke management. And the incorporation has been going hand in hand with the international recommendations also. Now, mechanical thrombectomy did not stop at the stage where it has been established in 2015, but it took a long dynamic improvement and progression. And this came together with the diagnostic as well as the improvement in the technique itself and application, and also improvement in the material that we use. It has been known from the beginning that the start was with something called the stent reaver, which is a stent attached to an introducer wire that you can retrieve together with the clot that you see, establish, and then pull together. Not time later, then they established also the use of distal, or what we call intermediate catheter with a large caliber to incorporate the thrombus and then suck it. So they have the aspiration first without the introduction of the stent. Now, later, a lot of variation came on with different names. Sometimes for me, it is very confusing, like Solumbra, Artis, Safe, Trap, ASAP, Protect Plus, but they are all just names. They all come into whether you use a stent retriever alone, you use a large caliber for aspiration alone, or you combine both together in the presence or the absence of a balloon guiding catheter. The improvement has also been in our technique to deliver the micro wire and deliver the micro catheter. So it came to the very specific points of whether you introduce the wire straight or you introduce it into an acute J shape, whether you keep the micro catheter while suction or you remove it to improve the suction. In my opinion, they all depend on the thrombus and the composition of that thrombus. The stents, likewise, they started with the classic Solitaire. Now Solitaire X is in the market. We have the Trevo, the Embotrap, Catch, and so on. The main point for me is how long you want the stent and the width depending on the place of the large vessel occlusion. The point that you always see discussion about is whether you use a hand or manual suction to retrieve the thrombus or you use a mechanical suction. It started with Penumbra with the pump suction machine. Now all or many of the other companies have introduced their own also suction pump. Still, I utilize both together. Now, the one point that you don't see any argument about is the balloon guiding catheter, and it has been shown by multiple different studies that it results in definitely less frequent distal emboli and improvement in the total clinical outcome in patient where balloon guiding catheter is utilized. Now, in Saudi German hospital and Medina region, we are the only center in the whole Medina region that provides the endovascular management in the acute ischemic stroke period. So we receive the patients either directly to the emergency department of the hospital or as a referral, which is most of the cases referral from other private hospital or governmental hospital, direct contact to us for the management. Once the patient arrives in the emergency room, then the whole staff knows that time is brain and brain is time. So we have to rush fast by assessing the patient. And once the patient is assessed, we know from our own experience and from the literature that as long as you continue improve on the workflow of your team or the stroke team, the better is the prognosis and the outcome of the patient. So in summary, we have an outline for the workflow in Saudi German hospital in Al-Madinah. It starts by receiving the patient. The laboratory investigation is taken immediately without delay, and the patient is assessed with NIH anesthesia department, is in the emergency room and the CT room while the patient is having the non-contrasted CT scan. Once hemorrhage has been excluded and the patient arrives within the time window for IV thrombolysis, then the patient receive it as a bridging technique until the patient is on the angio table, and then we proceed immediately with a CT angiography with a special technique to look for the large vessel occlusion. If the patient arrives before 6 hours, we don't need the CT perfusion. If it is after, then we proceed also with CT perfusion. We all know that we have different stages of ischemia, and the main point of catching time is to prevent the progression into completed stroke, which is irreversible. The patient is evaluated with several scores, including the NIH Glasgow Coma score, the modified Rankin score, and the ABCD2, which will help us to determine the prognostication or the outcome expectation for each and every patient. Now, we know that the patient has acute ischemic stroke. The CT non-contrasted is evaluated for the presence or absence of hemorrhage, the presence of MCA hyperdense sign, the early ischemia signs appearance, and from there we calculate the aspect score. The literature have shown that the early ischemia signs can be detected in up to an average of 70%, and this even comes with a high experienced interpreter. So if you did not see an early signs, this does not mean that an ischemia has already established. On the other hand, the hyperdense MCA sign represent the thromboembolic material within the blood vessel. This is not a very high sensitive, but it is specific because sometimes it can be confused, even especially if it is bilateral, with some other conditions like hemoconcentration, so the patient is dehydrated. Now, the aspect score is calculated in 2 levels on the non-contrasted CT scan, on the ganglionic level and on the supraganglionic level, where we look for the caudate, the lentiform, the internal capsule, the insula, and then the cortex. We divide into M1 to 3 at the ganglionic and 4 to 6 in the supraganglionic, giving a total number of 10 out of 10. It has been tried to be applied also to the posterior circulation, thalamus, midbrain pons, each taking 2 points, and then the cerebellar hemispheres, each taking 1 point, giving a 10 out of 10 points. But the accuracy of application on the posterior circulation is not as good as with the anterior circulation. And this is an example where you can clearly see a change comparing the right with the left changes, loss of the sulci on the left side. There is haziness in the basal ganglia region and the anterior limb of the internal capsule. And this is another example of an 81-year-old lady who was managed about 2 weeks ago, and you can see clearly the early changes in the ganglionic and supraganglionic level. Now, in my opinion, a CT angio is very vital in the workup, and it will not delay the management if it is done in the proper workflow of your team. And we look for the aortic arch, so you know the type of the aortic arch. You look for the origin of the great vessel, because this will help me in deciding whether I will go transradial or a transfemoral approach. Like a patient with a bovine origin of the left side, we went transradial immediately, while a kinked common carotid artery at the origin with a separate origin from the brachiocephalic will tell me to go through a transfemoral approach. At the same time, we look for the cranial lesion and where is the exact occlusion, and more important also to look for the angioarchitecture of the cervical vessel, because this will give you a hint where and how to park your guiding catheter, like in this 360-degree loops. Now, if the patient arrived after 6 hours hours, we proceed with the CT perfusion, and we do the qualitative assessment and analysis of the CT perfusion. We look for the maximum transient time, which represent the core infarction in addition to the still salvageable tissue around it, and we reduce or remove the cerebral blood volume, which represent the core infarction, and if there is a large mismatch, then the patient is a candidate for the mechanical thrombectomy, like this case of an MTT, and comparing it to the cerebral blood volume, we see a big mismatch. This patient went for mechanical thrombectomy successfully. Another case of a right side, a large MTT compared to the smaller area of CBV. So the cerebral or the CT perfusion is very helpful, but we utilize it only if the patient passed the window of 6 hours. On the other hand, if you want to do an MRI, then we compare the DWI with the ADC, and we see that there is a normal flare at the acute stage. At the same time, we look for the MRA, which can be done as a non-gadolinium enhanced, and then you look for the diffusion, the perfusion, again the mismatch, and you decide whether there is still a significant penumbra to be saved. Now, once the patient is announced as an acute neurological deficit within the time limit for mechanical thrombectomy, we'll look for the NIH and the aspect score, and we start immediately the bolus of the IV TPA, and we continue the infusion until the arterial access has been secured, or at the time of the access, and we stop the infusion at that time. IV TPA, with no doubt, was the only approved therapy for acute ischemic stroke, but unfortunately, it's only received by less than 10%, partly because of the limited time window and partly because of unavailability in all the hospitals around the globe. Not to forget the long list of absolute and relative contraindication. On the other hand, if we look seriously and critically into the effectiveness of IV TPA on large vessel occlusion, we find the more proximal it is, the less the chance and percentage for it to revascularize, like internal carotid is only 6% compared to a more distal occlusion. The recanalization rate also improved with a shorter, smaller thrombus rather than a longer, larger thrombus. But in my opinion, it is mandatory to be given. This is a bridging time, so you buy time until you establish the full recanalization or revascularization of the occluded region. It might protect against the distal emboli that might happen during the mechanical movement of the centrifuge or the suctioning of the thrombus, and it might help with the more distal occlusion if it is present. Now, it's not always clear and straightforward, but we have points that until now it is still debatable, and each has his own opinion. Like I started with the access, whether it is femoral or radial, some will get very stressed about the radial approach, and they will insist always to go femoral, the opposite for others. In my experience, I always depend on the results of the CT angio for the angio-architecture anatomy of the origin of the blood vessels and the type of the aortic arch. Nevertheless, we have to say that the radial first axis approach is our preference. Again, the status of the cervical will dictate to you where will you put your guiding catheter, especially that we utilize an 8 and 9 French catheters, so they will be dangerous during the looping or passing of a looping, especially if it is acute angle. Now, if we move toward a more distal occlusion, it is more debatable because the M3, some of the interventionists will argue against the benefit of it. We say that it depends on a case by case if the patient is affected clinically, even if it is a distal occlusion like this one, taking the distal M2 and the M3 site where it is recanalized successfully, and the patient in this example presented with sudden decrease in the level of consciousness. She was aphasic, hemiplegic totally, and facial palsy. Within the next 5 days after the mechanical thrombectomy, she became power 4+, no facial palsy, and she started talking. So definitely, even if it is a distal occlusion, it depends on the clinical presentation. Now, one of the terms that is really confusing to be used is what is called tandem occlusion. Well, tandem occlusion does not mean anything if you are not specific. It just says that you have 2 or more occlusions at different levels on the same territory. But you have to be specific. Are you dealing with an atheromatous atherosclerotic cervical stenosis or a dissection, which we see from time to time, especially in the young age group, or you are dealing with a mega embolus from the heart that occluded the origin of the internal carotid artery from the common carotid, or the more rare and subtle and mostly missed situation, which is the carotid cervical wedge. So you have to be very specific in defining what is a tandem occlusion in this specific patient. Like this is an example, a common carotid injection. You see branches of the external carotid. You don't see like this one, the internal carotid. After passing the microcatheter microwire and the intermediate catheter, we successfully and safely passed a long dissection in this young patient of 32 years old. And in this situation, then you will be faced with the question whether you revascularize the cerebral tissue first or you stent the cervical carotid. In my opinion, again, it depends on the case-by-case application. In this situation, I elected to revascularize the cerebral circulation. This is a young patient, no collateral circulation at all, and the dissection area has been temporarily secured with the guiding and intermediate catheter. After we established a revascularization, we used the combined technique, and then we had a good revascularization. Then we went down and we stented the carotid artery dissection, and the patient successfully went out of the hospital walking after 3 days. Walillah alhamd. Now, another point is the clot type, because with more patients you will find that you will be faced with different clot material. Some of the clots will come from the first pass. Some of them you try first, second, and even sometimes a third pass. And does not retrieve easily with you. So it's either a red RBC's clot or sometimes a whitish fibrous clot, which will be very difficult to be retrieved or not easily. We utilize the modified TICI score to evaluate our results, and this is one of the patients that showed a TICI 3 on TICI score. Another point that is of argument is whether you should manage patients who present with NIH score less than 6, because in the literature it is a debate. Some will say there is no improvement. Not only that, but it is of a higher risk for intracerebral hemorrhage. On the opposite side, you see some will say that it is totally safe, and on the contrary, it improves the results and outcome. And as I mentioned in the previous example, we take in between strategy that evaluate the cases one by one and decide on each case. Nevertheless, any case that presents with acute neurological deficit should be investigated immediately in the emergency room, including CT angiography without delay, even if he came within the window for IVTPA. While he's taking it, he should be evaluated for any intervention sooner or later. The aspect score, if it has been linked to the outcome, or the higher the aspect score, the better is the outcome, and it has been linked that the lower the aspect score, you have more incidence of symptomatic intracerebral hemorrhage. In SGH Al-Medina region, we adopt the technique of, if the patient has a low aspect score, we do a CT perfusion, and if we found a large mismatch, then we still go for mechanical thrombectomy. Now, even to add on the debatable points is the age, and some literature will tell you that the non-agenarian, those who did not pass the 90 years, should go for the mechanical thrombectomy, because although the outcome is less favorable than the younger age group, and this is of course expectable, but those patients will have better outcome than if they were not treated by mechanical thrombectomy and just receive the regular classical medical therapy. And we gave an example of this elderly lady of an 81-year-old with a CT perfusion, a large mismatch that we managed, and walillah alhamd, 2 days ago she went walking and talking home with her family. So still, even in the elderly, there is a place for application of mechanical thrombectomy. Now, stenting in the acute stage should be avoided as much as you can, and you should go for the other options if it will make you bridge the stage of acuteness in the first 2 weeks, and later on you can come for the stenting. Why? Because it has the additional risk to give the dual antiplatelet and then increasing the risk of intracerebral hematoma. This is an example of a carotid dissection that we tried balloon angioplasty twice, but every time it closes back. So we needed to put a stent during the acute stage and cover the patient with dual antiplatelet. Another section is the intracranial atherosclerotic disease, where you do the first pass, second pass, repeated, and you don't succeed in establishing a good retrieval of a thrombus, and then we utilize the angioplasty to open the stenotic area. But every time we pull out the balloon, the stenosis recurs with a total occlusion as we started. So we elected to stent it in the acute stage also. The patients who will undergo exclusive investigation, including the cardiology, the hematology laboratory investigation, rule out atrial fibrillation, and they still, we cannot find any reason behind it. So they call it cryptogenic stroke. That is a stroke without identifiable cause, and it accounts for up to 30%. But these patients have to be investigated really very carefully, and the interventionist should go back to the radiology and look carefully for what is called a carotid web, like we see in this patient. And we had been faced with a few of patients that been labeled as cryptogenic, while after going back and studying the patient carefully, we find a carotid web that needed management after the acute stage is over. With no doubt, we know that all clinical trials have came with the conclusion that utilizing the mechanical thrombectomy always outweighs the outcome of a standard medical care. And endovascular therapy not only improve the outcome overall at 90 days, but independent. The person will become independent in 80% of those individuals undergoing the procedure. On the other hand, it's not risky. Comparing the standard medical and mechanical thrombectomy, there is no increase or no significant increase in the intracerebral hematoma. Again, as we started, and Dr. Muhammad mentioned that time is brain. So the faster you act, the more you will be able to achieve a TK2B3 revascularization, and the more neurons that you can save with time. Bottom line and the message that we don't want to wait until we see a devastated situation like malignant transformation of an infarction, and this is a completed stroke, and then the patient will go from a complication and a procedure following a procedure and so on. It is always stroke should be looked as a bright face and not a dark face of the neurovascular management. We have covered the different techniques that we adopted in SGH and Medina Al Munawwara, and we started with this shape. This is how a neuron look when it is dying under the electron microscopy. أشكركم على الإنصات. Thank you very much, and I thank the organizing committee for this invitation. I'm ready for any question and open for discussion.
Thank you so much, our dear Professor Dr. Bassem, for that interesting and amazing presentation. I really get interested in it while seeing your case scenario and systematic approach, and you brought us with last up-to-dates in the field of mechanical thrombectomy. And I am lucky that I get work close to you at Saudi German Hospital Medina, and I witnessed a lot of success for use at that field and save a lot of disabilities. So great thanks to you from me and all neurology team at Saudi German and all people who learn with you, Dr. Bassem Sheikh.
And now, Muhammad, and this does not go by a one-man show. It's a real teamwork. We have in the hospital the neurology, radiology, the emergency room, who are in first line receiving the patient, the anesthesia, the angio technician, everybody is in the CT room and waiting for the patient to be shifted to the angio room. Jazakallah khair for the comment.
That's right. I totally agree with you. And I think you are the most one who believe in teamwork at Saudi German Hospital and encountered all stroke team members, like you said, pulmonologist, neurosurgeon, radiologist, anesthetist, intensivist. Every member in the team, you give him his importance, as we are like a machine with many turbos working together to bring the best performance and efficient treatment to our patients. Thanks a lot, Dr. Basim Sheikh. And now I am moving to Professor Dr. Usama Yassin, or Dr. Usama Mansour. For me, as a neurologist, when I was a neurology resident at Gamal Abdel Nasser Medical Insurance Hospital at Alexandria, in the first years of my training board, I have met Dr. Usama Yassin. He was the pioneer and the leading one for interventional neurology in Egypt, together with a lot of pioneers in Egypt. Dr. Usama Yassin, he has took the field of neurointervention in Egypt to at international level. And I am very happy to host him in our webinar. Shall welcome Dr. Usama Yassin, and the mic is yours. And I think it will be a promising presentation about future of neurointerventional here between serialism and realism. Dr. Usama, the mic is yours. You can start.
Thank you so much, Dr. Muhammad, for your kind invitation, and thank you for the organizing committee for having me to this very prestigious webinar of Saudi German Hospital educational activity. Thank you for the introduction also. And I think when I invited to present some talk on this for this webinar, I was asked to give to take the role of fortune telling on the interventional neurology or neurointervention future. And I think it's very, very promising. And let me first share my slide. This slide.
The slide is
my slide on screen.
You can make it larger to put all screen, Professor.
Okay.
Yes, it appears to us. Just
okay,
you can fit to all over the screen.
Now it's full screen. Okay.
Okay. Okay, Doctor.
I don't have anything to disclose, but first I would like to define the interventionalism. I think the interventional medical practitioner are a specialist who do minimally invasive procedure instead of surgery or the other treatment. And many specialists or many subspecialties are sharing such domain of the medicine or surgery, like cardiology, neuroradiology, neurology, neurosurgery, radiology, and vascular surgery. And most often these procedures utilize various imaging techniques and catheterization, puncturing techniques in order to diagnose and treat vascular and non-vascular pathology in the body. I think we should start back to the future to see how the field is promising and developing across the time. And the story starts since about 1 century or more than 1 century ago, since a surgical student have tried to realize an expert, which was at that time a crazy experiment. And this student was named, his name is Werner Frossman. He is German, a vascular student, and he was resident and tried to insert a catheter in his antecubital vein and trying to navigate the catheter from his arm to the right atrium, trying to prove that the catheter can navigate the vessels reaching to the heart. And during this era, this student has been fired from the residency program, and he was incriminated that he is using methods instead of medical science. And then the serials of innovative ideas based on these trials came up into the platform or the stage of the practice, where Selinger technique reported his Selinger procedure and how to use this procedure or maneuver to puncture the femoral artery, and other innovative ideas used to trying to have an access through different parts of the vascular system. And then through serials of evaluation, the endovascular technique and the devices have been developed so much as regarded the inventory for the ischemic stroke, starting from a trial with a wire and a microcatheter until now we have so many devices using either the stent retrieval concept or the aspiration technique, and also for the aneurysm treatment endovascularly, where just a simple coiling or filling the aneurysm sac with materials to separate it from the parent artery, until we reach it to different devices with different concept, which is either flow diversion or intrasaccular flow diversion or parent artery flow diversion, and so on. So like in the past, creativity was a sparkle for the interventional neurointervention pairs. I think the future of neurointerventionalists rests on the balance between creativity and innovation that founded our discipline in this practice. And I think this is stages of how to realize an idea. The idea starts like an imaginative idea, and then we use the creativity to realize such an idea. And if we are innovative enough, we can maximize the utilization of such idea for the sake of the population or large group of population. So I think the creativity is the first phase in development of our future. The creativity is the act of turning new and imaginative idea into reality. And if we have ideas but don't act on them, you are imaginative and not creative. And regarding the phase 2, which is very important, the innovation is the implementation of a new or significantly improved product or service or process that creates value for business, government, or societies. And I think this is a clear differentiation between the creativity and the innovation. That means that the creativity have a system and has a target to maximize the benefit for large amount of people around the world. And this is the difference between serialism and realism. I think this is the difference is can be defined according to items. Working on the idea to make it innovative and not just imaginative is like the difference between the serialism and realism, and how to regulate the world exposure to accept this new idea with maximal safety and utilization are those main pillars for making the difference between serialism and realism. I think also we should look in the history, and we can, if we like to take a look about the predictions, and we can see that mobile phones, Skype, robotics, and other very common ideas and the technology, high-tech technology now was just predictions from all the sci-fi movies, and that actually came true. And the credit, of course, go to the innovators, not for this just imaginative idea thinkers. So I think the innovation is very important. And I would quote this very important statement from Bill Gates: humanity's greatest advances are not in its discoveries, but in how those discoveries are applied. And example of current dissociation between the great ideas and the innovation is simply can be seen when we look at the status of the mechanical thrombectomy worldwide, and especially in the developing areas like our area of suffering from a lot of problems and obstacles that hinder the full maximization and the utilization of such very historical and phenomenal treatment. As Dr. Bassem said, the mechanical thrombectomy is a creative idea that benefit acute ischemic stroke with number needed to treat of 2.2. This is a historical number needed to treat a tool of therapy in the medicine, because I don't think that any other tool in the medicine can achieve such a number needed to treat in this number. And how to maximize its effect to a global stroke patient in the world? This is the catch, because till now, as also Dr. Bassem mentioned in his very interesting presentation, that the global burden of the stroke is very huge around the world, and we are trying to solve this problem for stroke patients, stroke victims. However, the effort is very minimally when we compared the number with the number of patients treated compared to the number of new stroke every year. However, some ideas in this direction trying to solve the problem, because we know that the accessibility of the mechanical thrombectomy is minimized because of a lot of problems. One of these problems in the pre-hospital stage, and this is why some innovative inventors try to increase the accessibility of the patient with large vessel occlusion to the nearest comprehensive stroke center, like using such devices, which is simple devices like the mobile CT unit, mobile stroke unit. It's two ideas. One of them is depending on the tracing the EEG activities from the brain of stroke victims, and it tried to grasp some pattern from these EEG waves, and it could differentiate between hemorrhagic and ischemic type, and by this way he can first give the patient the TBA in the stroke ambulance, and then it can also differentiate between the large vessel occlusion, the huge stroke affection, from the small stroke affection, non-large vessel occlusion stroke, and by this he can triage the patient to the proper site. And this is another technology depending on the ultrasound, and it is similar with a similar concept. So the activity is trying to decrease the time in the pre-hospital phase of the stroke patient to triage the patient to the proper site. Also, one of the innovative idea is artificial intelligence. And the artificial intelligence, using the artificial intelligence in the stroke workflow is very important, because sometimes the availability of neuroradiology is very obstacle and very blocking to the stroke workflow. So the artificial intelligence, like these two software, they could diagnose the stroke patient from the images, CT or MRI, and also he can diagnose which type of stroke, either it is large vessel occlusion or not, and also he can diagnose the site of occlusion, and by this way he can shorten the time for the decision making in stroke patient. We have in Alexandria an experience of doing such organization, and I think that this is very important when we come to developing countries, because it can receive the greater amount of attention in this regard. Why we should focus on the developing countries? Because these developing countries represent what's called unregulated markets. And the criteria for unregulated markets is that there is nothing which is formal regulation about which device can be used in this market, and what is formal regulation of using a new device in such markets. And I think when we look at this map, we will figure out that the only 35 countries around the world is highly developed in the world. And the total population in these countries is about 15% of all world population. That means that about 85% of the world population lives in developing countries. And this is a huge number of disease, and this is where the huge number of the problems and the huge number of unregulated markets. The importance of the item of unregulated markets come also and augmented from such a paper, which showed that even in very highly developed countries, the adherence to the guidelines is not as expected, is low, below the expected. So I think number one, the adherence to the guidelines is not as expected even in the developing countries. The presence of unregulated rules for regulating the practice in this part of the world can represent a very huge problem for this dark part of the practice around the world. And the problem in the unregulated market is simply the new device effect. What is a new device effect? It's the over-treatment sometimes, and on the more interventionalism and sometimes that can impurify the therapeutic effect. And sometimes this can be due to different factors. One of them is appealing even that it can reach to the obsession. The new device is a new hope, and this hope can solve a great problems in this part of the world. So that practitioners trying to use this new device and overuse this device, and also I think the creativity is sometimes need to be appropriate, and this new device is introduced to this market before it can be tested in a proper way in the original country. So we can use a new device without any new, any safety profile or any efficacy profile on our patient, and we can, at the end of the day, we can kill the practice. So we should be very cautious when we talk about the interventionalism, and we should compromise between what is the innovation and what is the serialism. The challenge also in our countries is the burden of the disease is high, and also the preparedness of the system is low. When we come to the WHO map for showing describing the neurologists around the world and the number of the neurologists and the neurosurgeons and the neurointerventionists around the world, this showed that when we come to area like our area, the number of neurologists is very few when we compare it to the other medical specialty. And also the number of the interventionalists is very few when we compare it to other interventionalists like vascular interventionalist or the interventional radiologist, general radiologist. So I think this all should be programmed in the mind of the person who trying to fortune telling the future of the neurointervention. And I think creativity is a fixed capital for investment in the future of interventional neurology or neurointervention. And it is working in 4 wheels. Number 1, the detection, the improving of the detection of the pathology. Improving in the detection of the pathology is very important. A degree of precision is needed, and the image can be static, dynamic, biological imaging. All of these are very important to improve our future and our practice. Materials, number 2, the spectrum between performing the task and the innovation of creating materials which harboring a higher safety profile and a higher efficacy profile is very important. And also the increasing and widening the basket of cases and accessibility is another wheel for the improvement of our field. And then I come to the 4th wheel, which is the operator. And I will talk on the will of the operator, because the burnout is very important, and the skill of the operator. When we come to the first wheel, which is detecting the pathology, I think innovation is working on the imaging to improve its precision of getting more information, and this information could be anatomical or could be physiological. And anatomical precision of the imaging is very important, and I think this is a very interesting work is going by South Korean and the Japanese group. They are using the COMPIM CT technology to determine the microanatomy of the vessels. Like in this image, you can see even the anterior spinal artery very clearly. And when you see something like that, while you are doing endovascular therapy like embolization, you can avoid inadvertent embolization of such very important and also very small vessels when you use a conventional angiogram. Also, they can show the lenticular striate very clearly. And this is very important also when you see, when you try to put stent for intracranial stenting and to avoid the atheroma to push on one of these small vessels causing a small stroke. And when we come to the pathology, also there is a very interesting work from same group of researchers. They improving the ability of the imaging to detect the pathological process. Like in this image, they used the COMPIM technology also to differentiate between the staple and unstable plague. The unstable plague with vasa vasorum in this right side image, while the left side image showed that this is stable plague without vasa vasorum enhancement. And during the procedure, you can use this information to use, for example, a distal embolization device when you decide to stent such lesion. And sometimes the precision needed during the procedure, like in this situation when we do flow diversion for the aneurysm, intracranial aneurysm, because of sometimes the malposition of the stent deployment can cause a very serious complication. And improving the ability of imaging to depicting the relationship between the device and the treating lesion by using such technique is very important during this procedure. And also another group from China using the OCT, intravascular OCT, to differentiate between the different type of apposition or malapposition of the stent, and they also showed that the communicating malpositioning of the stent is accepted, while non-communicating malpositioning of the stent is very problematic because it is associated with rupture of the aneurysm after putting the stent in a midterm follow-up. Then when we come to the physiological precision in the treatment, we can get more physiological information from the imaging. And this is very important when we come to the what is called the computational flow dynamic. And this is computational flow dynamic is a physiological detection of the flow inside the vessels or the aneurysm. And there is a long cumulative body of literatures showing that the association between the low shear stress is on the vessels or the aneurysm is associated with the rupture point. And you can use such technique or technology to predict the dangerous type of unruptured aneurysm and to select the aneurysm for the unruptured aneurysm for treatment. And also the using of QSME 3D reconstruction, which is SWI sequence from MRI. And by this sequence, you can detect the minimal leak of the hemorrhage around the aneurysm, and you can see that this is unruptured aneurysm is a dangerous and alarming aneurysm, and you can have a decision of treating such a weak situation. Also, you can use the CFD, the computational flow dynamic, in determining the high-risk subgroup of intracranial stenosis and to select them for the treatment. And this is very interesting work has been published in the last ISC conference from Lipskind, the group from UCLA, and they showed that the low shear stress, wall shear stress along the stenotic segment is associated with complications. So I think we can use such data to over-select the patient for stenting and who will get benefit from the stenting, intracranial stenting, and who will not get benefit from such procedure. And then come to the innovation where we can include all of this imaging technique in one theater, which is called the hybrid theater. And the neurointerventionalist can go with his patient to this theater. And in this theater, you see that there is an angiogram, there is an MRI machine, there is everything is available there. So the patient can be investigated during the procedure. And by this way, you can avoid unwanted complication and unwanted side effect. I think this is the future. Everything will be like a lifestyle, and this lifestyle will be changed like in coronavirus era. And the second wheel is the materials and devices. And I think I will not talk much on this issue because the following, the devices is rapidly improving from this the point of view. We should concentrate on the improvement of the steerability of the devices, the visibility of the devices, and the sometimes the biological and the anatomical specification or precision. And I think one of these innovation is the work that has been done in the steerability. Those are a group from French population or French researchers that tried to improve the steerability by using the magnetic control. And by this way, they can navigate with more and more and more accuracy to the target, especially in the very tortuous anatomy. And then we come to the biological precision of the devices, and I think there is a lot of work has been done in this direction from the drug-eluting coils to make this very effective and very therapeutic to improve and enhances the new endolithization of the aneurysm and the bridging the neck by the endothelium. And sometimes there is drug-eluting balloons and drug-eluting stent to avoid the re-stenosis and the recurrence of stenosis after a while. And sometimes the precision of the treatment concept, like in flow diversion, and to avoid putting a lot of materials inside the parent artery and keep this flow diverting device to the neck of the aneurysm, like these new devices which is coming soon to the market. When we talk about the visibility of the device, I think they are working very hard on both arms. Number one, the era of improving the radio opacity. I think this is improving more and more, and the era of improving DSA detectability. And I think it's going to improve regarding the ability of the DSA machines to detect very, very small details of the device, and by this we can use it to precisely deploy the device or use the device intravascularly. Also, the visibility on the MRI, it's a very interesting topic, and it's going on now. Even we can use this high spectral imaging technique, this MRI, to use to correlate between the intravascular anatomy and the extravascular anatomy. It's very important sometimes when you are in the angio machine to imagine what is the surrounding of this vascular anatomy from the outside. And this machine and this tool can save and preserve such imagination. And I think it's very promising. And when we come to the third wheel is the operators. And the operators, we will talk about the will of the operators and the scale of the operators. Operators is very important, focus for innovation and for futuristic overview of the branch. And I think two opposing forces are working on this item. Number one, the skills and the burnout. I mean burnout because this is coming, this graphs is coming from Atlas published by the WHO, showing that this is neurological devices worldwide, and the availability of this in different parts of the world. I think the first graph showing that neurological rehabilitation surface in the region, like in Africa, the red is absent and the blue is present. When we look at Africa, there is 18% of all Africa population is covered by neurological rehabilitation. And when we look up to the neuroradiology surface, I think also in Africa, about 18% only is covered by neuroradiological surface. So it's something which is problematic, that the number of preponderance or the rate of the preponderance of the surface to surface such patient is very low. And when we talk about the scale, we should mention the guidelines. And there is a lot of guidelines of publication coming from different societies, from the European Society of Neuroradiology, from the American Heart Association. Just write standards for neurointervention training, and Google will return with a gush of papers from different societies, consensus. And I think after the era of the mechanical thrombectomy, there a special focus has been paid for the stroke interventionalist, to the degree that when we look at different recommendations by so many societies, we can realize that there is some liberation toward the approval of the special category of interventionalists who can get special skills in stroke treatment to be able to start stroke intervention as a separate business. The rationale behind this liberation is number one, the need of the community to cover such a huge global burden of the disease. And the other cause behind this liberation is the tacit acceptance between sharing a specialty that stroke is a legitimate child of interventional neurology, and we as a neurologist consider it as carte blanche in the tough war between them to prove ourselves. So I think it's very important to have some guidelines clear for the neurointerventionalist, and these guidelines can determine which steps should be passed through to have the license to do intervention. And when we come to the burnout, I think this is very important, a publication showing that the burden of a stroke call is about 60% of USA neurointerventionalists meet criteria for burnout. So after the introduction of the mechanical thrombectomy, the incidence of burnout is growing up because, of course, so many disturbance of the sleep rhythm of the neurointerventionalist, and also the change of the lifestyle, the call 24 hours, 7 days, and so on. And this is another important publication showing that suicide is the first leading cause of death in the male resident, and suicide is the second leading cause of death in female resident, and 10% of medical students report suicidal ideation. So we are a vulnerable group of population. We have a high incidence of suicide, and when we put the burnout in the same basket, so I think it will be so dangerous to not mentioning on the burnout and the effect of the over-occupation from such business. This is also showing that the burden of thrombectomy, a neurothrombectomy call in USA is a problematic, especially if the call come in the night or nocturnal hours. It will disrupt the lifestyle of the interventionalist. So I think we should be balanced, be in a position balancing between achieving a high skillful practitioner and avoid the burnout of the practitioner, because as we know from the number of the neurointerventionists in our area is very limited, and we need to achieve a high learning curve in a very short time period. And at the same time, we should avoid the burnout of our practitioners. So this brings me to the next item, which is a simulation in the training. So we can use some tools that can increase the adherence of the practitioner to the training and to the specialty by using simulation. I think this is not a dream. It's something which has been published in the literature recently, showing that using virtual reality and the simulator, both in the training and the preoperative preparation of the treatment of difficult cases, showed a dramatic effect on the outcome of the patient. And I think now there is a very unique company which is working in this direction, Biomedics. It takes the FDA approval of their tools of simulation. It's working in the preparation for the treatment of difficult cases, and they started working on unruptured aneurysm, which is a big situation in deciding which treatment should be provided for this situation. I think in this not only, but it is promising through integrating virtual reality and the haptic technology to create a special training modules. This is a paper, very interesting paper published in very prestigious journal in stroke, showing that by combining the virtual reality and the metric-based virtual reality and the haptic technology, they can create a platform that can get information from the hand touch of the operators and guide the operator to do steps in a special way. So I think it's very interesting, and making the training as enjoyable as playing WWE PlayStation game and selecting which superstar you will wrestle with. For example, you can choose from this all superstar. And then we come to the robotics, and this is a new era in the neurointervention. And I think the news is coming excessively about the first use of remote robotic brain surgery or remote robotic endovascular treatment of aneurysm or carotid stenting. And the first one was in Toronto by a group of Toronto of interventional neuroradiologists. This should raise the realistic question about when and we could use it in which type or in which situation. I think in practice, this is very interesting when we use this technology in decreasing or briefing the learning curve of the learners or the trainers, and also to decrease the burnout and to balance and to try to make it cost effective. And in telemedicine, we can use it to reach the very far and remote sites, like reaching to the sub-Saharan countries in Africa, where a number of neurosurgeons and interventionalists is almost zero. So I think it's very important to use cautiously such technology in our practice, and especially when we come to the number of stroke interventionalists in Scotland that has been published in the Herald, showed that all Scotland have no neurointerventionalist, and they are calling for any neurointerventionalist from the world. This is very rich country with high income, and they don't have the enough number of neurointerventionalists. They can use such remote technology to solve such a problem. But when we come to our regions, it could be a real surrealism, because this graph shows that the availability of internet and the connectivity in our region, especially in Africa, is only present in 1% of population. So it's a very problematic situation, and a very huge question need to be answered, how to utilize such technology in our region. And then we come to the last wheel, which is the pool of the cases and the accessibility. And I think we are, as a neurointerventionalist, we are in a full agree that the endovascular or the neurointervention is working very good in this indication, in acute ischemic stroke, in intracranial aneurysm, in carotid angioplasty and stenting, yes or no, in intracranial atherosclerosis, and in embolization of arteriovenous malformation and dural fistula. However, this is not the whole cake. This is a small portion of the cake, and the other portion is hemorrhagic stroke, hydrocephalus, neurodegenerative disorder, headache and neuralgia, treatment, interventional neurophysiology, epilepsy and memory, and the brain tumors. Those fields are also a stage for the neurointervention, and I will show this literatures or the publication showing this. And I think it's very important when we come to the hemorrhagic stroke, we will talk about the chronic subdural hematoma, intracerebral hemorrhage, and the role of neurointervention in hydrocephalus. The magnitude of the chronic subdural hematoma in UCA, the prevalence, annual prevalence, is about 17 cases per 100,000 person. And this increasing prevalence is expected in the coming few years because of aging population and the overuse of anticoagulation and antiplatelets. So I think this, when we compare the number yearly of the chronic subdural hematoma and compare it to the subarachnoid hemorrhage, regarding subdural hematoma yearly in UCA, there is 60,000 cases per year, and versus of 30,000 cases of subarachnoid hemorrhage per year. So this is the magnitude of the problem, and some of the American group used a very innovative technique, castrating the middle meningeal artery, which is supplying the dura, and embolized the dura from this artery through the microcatheters, And they proved that this technique and this approach is working very good in chronic subdural hematoma. And they published so many publications in different prestigious journals. And this is one of cases showing that these patients have a chronic subdural hematoma with different appearance in the subdural lesion. And middle meningeal artery has been catheterized, and BVA was embolizing here. And then this is the CT after 1 month, and this is the CT after 3 months. So I think it's working very good in this regard, and it is an opening stage for the neurointervention in this part of the pathology. When we come to the ICH, I think also we know that 10 to 15% of all stroke are ICH, and no proven medical or surgical intervention has been shown to significantly improve outcome or reduce mortality in ischemic in intracerebral hemorrhage. There's two minimally invasive techniques that can be used to evacuate the hematoma, and these two devices which are under trial now and under study, the Artemis one and the Reach one, NICO. And they published so many promising results about the effect of these devices on removing the hematoma. And it's very simple that you can do a per hole, and using such small pipe to suck the hematoma. And you navigating such devices using the CT, stereotactic CT device. And at the end, you can apply a negative suction on the hematoma using a pump like the penumbra pump. Even they can go to a deeper site, a ganglionic hematoma, and they showed that it is effective also in such a situation. When we come to the hydrocephalus, there is a very innovative idea that they can go from the transvenous approach, reaching to the inferior petrosal sinus, and then they puncture the inferior petrosal sinus to the CB angle, and they introduce some small device, or a small, very small device. This is a tube, small tube with a valve. And by this way, they can create a shunt between the cistern, CCF in the cistern, and the venous system in the inferior petrosal sinus. They published about their experience in about more than 100 cases, and they showed that it's a promising approach. And when we come to the neurodegenerative disorder, which for a long time represent obstacle and the block for the hope of all neurologists around the world, because the prognosis of such a disorder is very gloomy, like Parkinson, Huntington, ALS. There is a group of researchers that used a very interesting technique, also through the stereotactic and direct puncture of per hole or something like that. They introduce what's called the adeno-associated viral vectors, trying to retreat or to heal the knockdown mutation in the Huntington patient. And they started their procedure on the animal, and they published the experiments, their experiments and their results on sheep, and they are showing some interesting result in this regard. And then finally, we can go to what is called the interventional electrophysiology of the brain. And like in cardiology, there is what's called the interventional cardiac electrophysiology. After this innovative device that has been invented by Australian researchers, this is something like a stent root carrying very small or micro electrodes, like here, introduced to the venous sinuses and deployed inside the venous sinuses of the brain. And it can detect wirelessly and trace wirelessly the EEG waves of the brain. And by this way, we could utilize such a device in epilepsy. For example, when it could be applied to record the onset of the epileptic seizures and provide stimulation to prevent the epileptic seizure before it happens. And there is also some group working on this concept, and I think they showed some interesting result in the last epilepsy conference in USA. And when we come to the headache and the neuralgia, Adnan Qureshi showed the important concept of injecting lidocaine in the middle meningeal artery in chronic non-responding migraine.
So, Osama?
Yes?
Sorry for the interruption. We have only 20 minutes. And we have also one speaker, Dr. Islam, for us.
Oh, okay.
That presentation will end this one, or we have another?
Sure. I have one slide. So I think the intra-arterial trigeminal nerve ganglion block is a very promising another approach for in neurointervention. So in conclusion, I think the future is very bright, and the potential of these new technologies to improve the patient outcome is incredibly exciting. And we need to expand our circle of procedure. Likewise, interventional neurologists should avoid presenting themselves as a stroke interventionalist only. And in developing countries where insufficient organization of healthcare services and the lack of resources and the lack of trained physician, code of ethics to present new devices, new technology, and a new procedure is warranted. And even we need to adopt a new region adaptive guidelines to increase adherence to safe practice guidelines. It's very important. And at the end, I would like to invite you to the next MENA Sino. It will held in virtually this year, the 5th MENA Sino, from 25th to 27th September. And a lot of prestigious speaker will be our guest speaker during this. Thank you so much.
Thanks a lot, our Professor Dr. Osama Yassin, Professor of Neurology and Interventional Neurology at Alexandria University, and head of MENA Sino group. Really, it was interesting, amazing. I think you took us to the future. Dr. Islam, he is sitting beside me and watching your presentation, and always we have comments. This is new, this is up to date. Is it done already or not? Is it generalized or still limited in certain centers? So I think you took us to advanced level of neurointervention, and all neurointerventionists will appreciate that presentation well. And now I am going to present my dear senior Dr. Islam, lecturer of neurology, Tanta University, and interventional neurologist. He will present us a presentation on controversies of mechanical thrombectomy for acute ischemic stroke. Dr. Islam, you can have a seat.
السلام عليكم ورحمة الله وبركاته. Just I'm going to open the presentation. It's okay. You see the presentation? I think it is. Zoom. Check. You see the Mr. Ala?
تمام
It's
دكتور.
okay.
تمام دكتور.
Before beginning my presentation, I would like to thank Saudi German Hospital for this opportunity, and also thank Muhammad Fouad, my brother, Professor Basim Sheikh, Dr. Osama for their presentation, and I will try to be fast because of the time, the short time remaining. Presentation is about controversies in therapy of ischemic stroke. It is already that the endovascular management of the acute stroke and the guidelines since years, but still there is issues debatable. Presentation today about the debatable issues. This is about Mercy device, the first that we used in 2008 regarding thrombectomy, and a lot of stent retriever can be used. The stent was solitary. I will discuss lesions, patient on IHSS by acute stroke, vascular management of occlusions, acute artery occlusion, rescue and stenting, anesthesia local versus general, endovascular thrombectomy alone versus bridging therapy in proximal vessel occlusion. Definition of tandem lesions, as most of us know, that is combined of both proximal interrotted distal pass in the cerebral artery. About 10% of presented tandem pathology differ between either atherosclerotic plaque versus dissection. In all cases, the primary focus should be treatment and access to the symptomatic lesion is the distal lesion, is to open the middle cerebral artery because that our target, because as we all know, time is brain. After that, it comes. Opening is a cerebral, whether make a concept management to the carotid or go to angiography with or without it. This is the case internal artery with cerebral artery.
بس الصوت شوي عم بيقطع، لو تقرب شوية على الكمبيوتر الصوت عم بيقطع.
It's okay now for the sound? It's okay, Mr. Ala?
Yeah. Thank you, Doctor.
Okay. This is a case with internal carotid occlusion presented by middle cerebral artery stroke with big penumbra. First, it is what the intervest first stenting carotid and then go to the middle artery to rise. This is finishing. The for conservative approach, no stenting is that in most cases, the cerebral occlusion in a difficult need to do remove the carotid. Thing is primary lateral circulation was already present because chronic after getting the of opening in that what is cerebral perfusion. It can the auto mechanic and flow to area, especially anti. There is the advantages of doing angiography or to get access to lesions. Some cannot access the lesion without the angiography, but some have to do. Also, the capacity with stenting improves the flow and prevent recurrence in that phase. In dealing with carotid occlusion, is that when instant hemodynamic from lateral, it is better to at least angiography without stent. If we have good drugs, we can angioplasty stenting we get cerebral perfusion. Still debatable. Most of the interest now, I think the they do plastic anti double antics and that are encouraging how it increase the risk of hypertension in Egypt. Some patients present to IHS 6 to confirm in some of the patients. Patient large solutions with what presented in ISS below 6. And here's the count with a vascular thrombectomy or waiting will be progress. It is a case presented acute stroke. The CT brain is free, dry, very small lesion at global flares us middle artery showing there is broken solution and this is the MR the patient show one open and unfortunately there is no available vascular therapy during implantation. The patient with middle artery lesion, patient with NSS 5 following condition, and there is low NSS, there is deterioration and to do conservative management. Sometimes we can of the large. There is a conservative management of such IHS patient giving medication yielding the same outcome without advantage of the intracerebral with increased symptomatic hemorrhage such patients. In such patients, we have to assess collateral circulation during DTP CTA. If there is bad collateral, it is advisable to direct and do endovascular thrombectomy if no NIHS those with lateral put into it occlusion during as the case we show previously. Endovascular intervention can be done if the collaterals are okay, if the patient collateral, we can observe the patient very and we can intervene, do intervention, additional progress. This is advice by Berlin. Endovascular treatment sometimes we the occlusion is a big clinical like guidelines we mentioned M1 carotid does not mean two occlusions and also the occlusion, but some we have distal organ but with very with high clinical impact and morbidity. As we see, branches of the membrane cause very harm like the branching and responsible for which is high mobility and that's in the distal to be based are just venous slices and the rationalities the intraluminal processes in good distal at the same time the rationale go to the infrastructure to open those traces that during this for small cells now because of technical the advances in the is very easy with the some of those distal this solution is high morbid clinical. The decision is depending on the terms, age, clinical of patient. So it's better when the distal occlusion there is clinical act with important young patient. What in opening vibrations and sometimes the angle we have to the center. Sometimes, so if direct observation we have to use a retriever. This is the acute basal occlusion. A very important subject is present intratracheal stenosis, aortic stress, thrombus in acute occlusion. 0.44% of the present acute and intratracheal. Those who can clinical characteristics, mostly they can young age and also present low in ICS, mostly low because of the circulation, because of the contracting stenosis. Also can recognize during the intervention because we have even after artery very thrombusization extraction, and if you have stress, those patients start to rescue because the chance of we do plasty and stenting after thrombus. Also, the cranial after thrombus, they have a high chance of occlusion. Then the first after thrombectomy and drop gain. The latest application is that in the setting acute intratracheal stenosis. This is cerebral occlusion. After normalization, we have residual stenosis here. This is after angioplasty and distinct. In most patients, who relate the throat being, they can have function even the flow is circular. They have occlusion first after realization. So it is better to do stenting. This is a case of the basilar. This is after we can get it. So this is after the angioplasty. Without we use the operation. This is thrombus. The thrombus. I do aspiration. Sometimes the aspiration because of the sometimes it works. I do not. So later patient, if we success this underlying of this to do retrieval direct vibration. After getting the thrombus, if we let the artery, it will mostly re-occluded either in the same setting or in the first one after the recanalization. So better to inject arterial cap or doing angioplasty and stenting. Most of the literature showing now that with using angio and stenting, even with double platelets, there is much increase of after the double platelets, and outcomes if we let it with a rationale use the general anesthesia. This rationale is to keep the patient calm during the procedure, to avoid the aspiration because the danger of aspiration we just look at anesthesia. So improving realization, reducing scope time, but finished. Okay, because of the time, we have to hurry. For the local anesthesia, the advantage is to assess the patient during the procedure. If there is little, we can go and to give the hemodynamics, because with the anesthesia induction, sometimes hypotension, and hypotension lead to hypoperfusion during the procedure, and this will harm the patient. So the bill is, if we have an experienced anesthesiologist with rapid induction technique, rapid induction time, it's hard to use general anesthesia, especially if the patient is neurologically, dynamically unstable, the patient is uncooperative. So better use the general anesthesia than the local anesthesia. If we do such anesthesia, we can use local anesthesia with concentration, consider normal pressure during the procedure. This is vascular techniques that we can. This will be the last slide because of the time. Either we use just stent retriever or distal aspiration thrombectomy. So number using both line aspiration catheter and tail, but use the large balloon-gated guider to give the aspiration and the stent to inhibit propagation from basal inhibition in distal inhibition. We use against distal inhibition to opening the engulf both stent and vas. Out of aspiration, we can, and all aspiration device can choose to the patient case by case. Thank you very much. I'm sorry for being fast. Now,
thank you so much, Dr. Islam, for that super presentation. And we have a lot of questions.
Muhammad, sorry for interruption. Muhammad, we don't hear anything from you.
Yes, Mr. Ale?
عم نسمعك يا دكتور.
Do you hear me well?
Yeah.
Thank you, Professor Dr. Islam, for that super presentation. And firstly, we have no much time to get our questions for speakers to discuss it. We have to end our webinar. Thank you, all speakers. Hope to meet you again in another scientific event. And thank you to all audience. Thank you.
طيب, at the end of this webinar, please, Doctor, stop sharing.
Okay. Mr. Ala, you can finish from your side because there's technical problem.
طيب, at the end of this webinar, I want to big thanks to Professor Dr. Osama Mansour for his valuable lecture, and also for our beautiful neurologist Dr. Islam Dusuqi, and of course for our moderator Dr. Muhammad Fuad for magnificent moderating this webinar, and big thanks to our Prof. Dr. Basim Sheikh. We are proud in Medina Society to have like this doctor between us. دكتور نافع الله بكم جميعا وبعلمكم دكاترة الأفاضل، وبالأصالة عن نفسي وعن أهل المدينة أشكركم جدا على هذا الويبينار. شكرا لكم. السلام عليكم.
شكرا عليكم السلام ورحمة الله وبركاته. شكرا دكتور محمد، شكرا دكتور إسلام، شكرا.